I think one of the things we are all familiar with is the triple aim. I think we really have to go beyond the triple aim to the quadruple aim, and that includes provider satisfaction. We know that there is a lot of physician burnout, and we know that it's getting harder and harder to engage primary care physicians. So we really have to take our model, and we're taking our model from one which focuses really on the physician and the physician treating the patient to one of team-based care. We need to bring that joy of practice back into the primary care provider offices. And so what we've done is we have really looked at the model in which we care for patients. So, 80% of our patients, when they are discharged from the hospital, they're pretty straightforward. A traditional transition of care which follows CMS guidelines, in which there's an outreach, there's an appointment within 7 to 14 days. We follow that patient for anywhere between 30 and 90 days, and in most cases, hopefully there's not a readmission. I think with 10 to 20% of the other patients, they really need more things which meet their psychosocial needs. And so we need a multidisciplinary team. And we're really getting away from a more nurse-heavy model to one which encompasses behavioral health specialists and integrating those behavioral health specialists right into the primary care practice. Many people receive referrals with issues around behavioral health to psychologists or to resources, and they don't follow up on them. When we integrate that into the primary care, they're much more willing and able to engage in those, meeting those needs. I think the other piece is the introduction of community health workers into the team to supplement what the nurses do. And that comes back to, I know it was brought up in the last panel, about people working to the top of their license and picking the right people to do this. When we look at these community health worker type positions, we're not looking for credentials, we're looking for passion, people who are passionate about bringing things to our patients and meeting patients where they live.
Thank you. Hi. Thank you for having me. So I will supplement this by saying that really in practical terms, what we're doing is actively working to develop care coordinators and patient navigators. How many of you have patient navigation system? Okay, so basically these two are within our care model. Clinical care coordinators have to be an RN, whereas a navigator can be a social worker, can be an LPN. Sometimes it's a promotional opportunity for medical assistants. And these two entities function sort of like a goalie in a soccer game. So that the nurse the clinical care coordinators get assigned a small panel of high acuity patients that actually require clinical knowledge of a nurse. So 25 to 30 patients that they follow through after the discharge. And then patient navigators actually partner with patients, and patient navigator may have 250 patients in their panel. So these are low acuity, high volume setup. And what we've done is actually introduce a role of patient navigator into our emergency room so that every patient that is discharged from the ED actually gets, and we did some studies on it, comparing patients who were discharged from the ED and the frequency of their return to the health system when they did not have a contact with a navigator and when they did have a contact with navigator. And we are seeing 40 to 50% decrease in ED visits. So it basically pays for that FTE, because once it's basically what we heard about relationship building. Once you build that relationship with a human being and you begin to, basically change happens with a speed of trust. So once you build a relationship with another human being and you start building trust, then that's the route the patient will then choose to have an appointment with a primary care physician with an ambulatory care system, as opposed to going back to the ED the way they've done it, you know, and it really is kind of a habitual situation where they've done it for 20, 30 years of their life. So these are a couple things that we're doing, and yet another thing that we're doing is my colleague mentioned community workers. In our health system, we actually engaged with pastoral, non-dominational, sort of pastoral spiritual care, and that's the angle that we are, that from which we are recruiting those workers. So that it's not a clinician as much as it is a person who will sort of guide them through a little bit of a reflection on life. But we are fine, particularly in the community where we live, where it's Newark, New Jersey. It's a community that has gone through a trauma of the 60s, where actually our hospital was on fire during that time. I'm not kidding. And 50, 60 years later, the community has really, through the spiritual pastoral care, they've been able to survive. So we're finding those connections to be quite effective in managing their behavior.
Those are both fantastic answers to the questions, and I can't reinforce the importance enough of having that continuity of care handoff post-discharge, post-ER visit. One of the things that we also employed, which you were talking about, is the health coaches from the same cultural community that the patients come from. And we share in New York the same situation as Newark and many other places. When I would go knock on a door in Spanish Harlem, they think I'm the integration department ready to evict them to whatever country they come from. But when someone from their church knocks on the door and speaks their language and can go into their houses and do assessments for us virtually, that's amazing. One of the things we did for our navigators and health coaches is we gave them iPads so they can literally take pictures of the medication reconciliation concerns that the patients have so that we can Skype with them, or FaceTime, I guess we call it now. My kids would kill me for saying Skype. And then say, oh, no, don't take the blue, that's not the blue pill, take the red pill. It's so confusing. So those are really great best in practices. Our next question for our panel is, are there cultural or generational considerations to the work, and how do they impact on care coordination in academic medical centers? Barbara, do you want to start that?
So I'll take this one. Historically, we talked a fair amount about health literacy and how we need to communicate for the patient to understand the message. And I strongly believe that because we now live in times, we live longer, and so it's the first time really in history that we have 5 generations using healthcare services and 4 generations in the workforce. So we start from traditionalists that remember Great Depression, and we go all the way to 2-year-olds that have not held a book, perhaps, because they've been raised on glass. And so the more we can be sensitive to the influences of how each one of these generations grew up and the formative events during their growing up, right? Second World War, Great Depression, very different from, flower power and the Beatles, and then again very different from when the market crashed in 2008, or the discovery of contraceptive pill is vastly different from what the internet brought to us. And so each one of these generations, and they have different expectations of healthcare, they use different language, they engage with us as providers. So, I'm sure you've experienced the attention span that millennials have, for better or worse. And so to the extent that we can figure out a way, so this puts a fair amount of stress on the system, because on one hand, we're trying to get off paper and be fully electronic, but then how do we not lose those older, and yes, these days 85-year-olds have cell phones, but not all of them have cell phones. And by the way, I'm sure everybody here has one of these, but how many, this is a question to the audience, how many of you used this to pay for your coffee this morning? 1, 2, yay! So see, so then how do the rest of us create an environment that would cater to the two souls, two brave souls, you know, who use whether it's Apple Pay or you know, Google Pay, because that's really where it's going. And frankly, we now have the Facebooks, the Googles, and the Amazons, and they do not cater to the 99.99% of the room that did not raise their hand, right? And they will have a bigger and bigger voice in what's happening in healthcare. So I will stop, and because there's only so much time, but the point of it is that we really, just like there's a lot of personalized medicine concepts, we really need to focus on, I think, on personalized communication to be successful in coordination of care.
Jeanette, you want to add anything?
Thank you. Yeah, so I think one of the things we need to think about, yes, certainly religious and cultural beliefs affect a person's understanding of their illness and the medications they take to treat their illness. And we have to kind of like break down those cultural myths around disease, you know, and oftentimes stigma that's associated with disease, because until we can break down those things, we cannot help these people to self-manage their chronic disease. I think the other things we need to think about is, one, we need to have a workforce that mimics the communities which we serve. I think that's a really important piece. People are much more likely to be open to us and to do more shared decision-making and helping people to self-manage their disease. And I think it's important to measure disparity. I think we often have assumptions about the disparities that take place, but it's important to measure it. And we learned this firsthand. We recently participated in a grant from the state of Connecticut in which we were given some money to help we thought of it as seed money to help hire a couple of community health workers / navigators and an integrated behavioral health specialist to one of the primary care practices. And what we learned is part of the requirement was we had to actually drill down on our data, our EPIC data. We are an EPIC house. And first and foremost, you need to collect data at a granular level, right? You can't just say, or is it Caucasian or African American or Latino. You need to collect data at a granular level and then measure that data and measure it relative to their chronic disease and their abilities to manage their chronic disease based on, you know, gaps, gaps in data. So you learn things like people who are Latino, who may be Puerto Rican versus Mexican, what's their usage of the ED if they have asthma, a chronic disease such as asthma? And then that helps you when you look at those disparities and truly discover what they are to address them at a level where you're more likely to engineer better outcomes.
Great points. And when you're talking about intergenerational communication with your patients, you know the best way to assess how best to communicate with them? Ask them. Simple. Ask them. I have a 92-year-old father-in-law who plays 18 holes of golf and rides his bike every day and has iPads and is very high-tech. My mother-in-law, his wife, however, has one of those flip phones, and if you asked her how to communicate, it would be send me a letter. So the best way to communicate with people is don't assume and just ask them. Okay, our next question is how can you impact social determinants of health into workflows to target utilization and utilizers of ambulatory care? Jeanette, do you want to start that one off?
Yeah, so I like to talk about a tale of two Connecticuts. So if you look at the median income in the state of Connecticut, it's about $76,000, which sounds wonderful. Yale covers, we have hospitals, 5 hospitals throughout the state of Connecticut, one in Westerly, Rhode Island. And if you look at the 2 urban areas we serve, Bridgeport and New Haven, In Bridgeport, the median income is $38,000, and in New Haven, it's $43,000. So it's important to know the community that you're serving. And then I think the other piece is how do you, we know that addressing people's social needs, socioeconomic gaps, will bring down things like ED utilization. And again, here's where those community health workers / patient navigators are key, and getting into people's homes, meeting people where they live, and discovering how to change behaviors, because this is hard, this is really hard work, right? We have learned that we have about a 30% disconnect rate when people screen positive for housing, utilities, food. There's about a 30% disconnect rate. And we actually saw that independently in both the New Haven and Bridgeport area. And it's for a plethora of reasons, including many of these people, you try and communicate with them, and they have government-issued phones, which run out by the middle of the month. They run out of their data. So it's how do we communicate with people, and how do we engage people? I think the other piece of this is that there are limited resources. So how do we understand and know what the resources are within our communities that we can direct people to? I believe from Kaiser Permanente, they talked about Unite Us. We are actually going live on Unite Us in the next couple of weeks, so I was happy to hear about their experience with that, and we look forward to it. I think the other piece is, again, looking at it from the micro and the macro perspective. So you must screen at the patient level for social determinants. When you find out things around housing and food, then you need to take it to the next level, and that's where it's the person who's asking the questions and how these are sensitive questions. So we do a lot of training with people on how to ask these questions so that we elicit the truth from these people, because we tend to underestimate the socioeconomic needs. And then there's the macro level. So how do we collect this data around housing and utilities and bring that to organizations within our state so that they can look at where to invest money in terms of additional resources that may be necessary? You know, housing, you know, certainly I'm sure rings true with most everyone in this room around how difficult it is to find not only housing, but safe housing for people. And then I think last but not least, it's understanding that there's stark variation from community to community in terms of what the resources that are available are. So again, it comes back to having a good resource library that you can utilize to link people up with better community-based organizations, and then creating a way in which you can tie the loop when these people meet up. You cannot just hand someone a piece of paper and say, here, go to this food pantry. It's not going to happen. These are people who are totally overwhelmed. And so you've just given them one more thing to do. It's really about utilizing the right staff to hold their hand through the process and guide them through, and to build those trusting therapeutic relationships.
It's excellent. Thank you. Barbara, want to add anything?
So I would just add, and you may or may not believe it, but in Newark, New Jersey, after the riots of 1967, for about 30 years, there was not a supermarket, a grocery supermarket in the community. There wasn't one until the 90s. So you can just imagine what that did to the community as far as the food, access to healthy food, food security, and so forth. So that's sort of the environment that we are now really trying to decipher the social determinants of health and how to best impact it. And so what we're doing, again, from very practical standpoint, we just engaged with a company called Hitch Health, which is sort of like Uber. How many people have heard about it? It's like Uber or Lyft for healthcare transportation. And basically, this is, for now, we're just piloting a project for primary care so that anybody who lives within a certain radius of the hospital basically has an app, and several of our, like obviously it's a process. We need to make sure that the patient has a phone and has an app on that phone. But the patients are able to actually use the app and get the transportation to the hospital or to the whatever the care that they seek, to the doctor's office and back from the doctor's office, because we found that transportation insecurity oftentimes prevented them from coming, and then they would come through the ED when it's really too late.
Great, thank you. My next question is, how have you begun to use predictive analytics in modeling to reduce unnecessary ED admissions?
That's not easy. So I will say that we've had some experience with predictive analytics. The bulk of it has been through claims-based data. And what we've learned is it's really hard to use just claims-based data for this because it tends to weigh heavily on past cost. And past cost is not necessarily predictive of future cost for a person's health care. I think what we're looking at right now is how do we take, we're very fortunate as a health system, we're a total Epic house. So how do we take that Epic, that clinical data, and marry it to the claims data and use that combination to be a predictor of who are the highest risk. And when you think about resources, who would benefit the most from care management resources?
Thank you, Barbara.
Yeah, so I would just add that, on the note of this, the exercise that I just described with Hitch Health, we've partnered with University of Pennsylvania, and UPenn has actually I get no royalties, so this is not a UPenn advertisement, but they're very open with the analytical tools that they've developed specifically for pop health. So this is just the beginning of the project for us to sort of identify the zip codes where patients live and figure out who is at greater risk for missing their appointments and who really needs that help with transport.
So I just want to say, totally agree with that. I mean, I think zip code is going to be a very important piece of predictive analytics because really our zip code is our ZNA. There is no better predictor of life expectancy right now other than looking at a person's zip code.
I like that. I never heard of ZNA. That's a pearl for me. I like that. Very good. Okay, we have one more question, and then we want to open it up to the audience for you to ask any questions of our expert panelists. So my last question is, what trends do we need to be mindful of when we consider modifying our care coordination models? Go ahead, Barbara. You want to take that?
Sure. So as I mentioned before, I think that sort of the need for personalized medicine and personalized service is going to continue to emerge, and a greater need for specialization or subspecialization for service. We now have, which we didn't have before, just beginnings really of price transparency. We all now are obligated to post our charges, or sort of like price list, make it available to public. And I do think that we are actively moving to really more and more focus on service. So while we think that we shifted from way back when physician-centered care to more patient-centered care, I don't think, given how much the universe has opened up with access to information, I think that the kids that are now 5 years old are going to become much more sophisticated consumers than their grandparents. And so we really need to be ready for that. And the big elephant in the room is what's going to happen with Haven, which is the Berkshire Hathaway, JP Morgan, and Amazon. And those of us who are in a sort of traditional provider settings, like both of us, academic medicine, I think that we really need to watch out because, how many of us are wearing these devices, right? Actually, both of us, yeah. So But effectively, we are all being tracked, our pulse, and the exercise and all of that. So I do think, obviously we don't know yet what it's going to be, but I think that we are going to see disruptions in healthcare like we've never seen before. And I also think what we need to be mindful of is we are going to see disruptions in the workforce, because a lot of workforce is going to become automated. Many of us, most of us probably had to fly here. So when you're in the airport, like you sit down to get a bite, there are no more waitresses coming to you, right? There's iPads everywhere. And so I think that this is just a beginning. What we are seeing now is a beginning really of workforce revolution, that we will all, some people will lose their jobs. And how is then that going to fit into what we are now, calling social determinants of health? So I'll just pause here.
Absolutely.
I think one of the trends we're witnessing that is impacting care coordination is this drive in the commercial world to these high deductible plans. Like how many people in the room are on a high deductible plan? I actually cannot raise my hand on that. We actually are not on a high deductible plan. I think at the inception of high deductible plans, the thought process was that would drive people to shop for their health care. It's actually not done that. It's shut people down. It shut people down, and they're not seeking health care. And ultimately, I believe the costs are going to rise as a result of that. I think the other trend we're seeing is more and more employers have become self-insured. And so they look at their claims, they study the total cost of care ad nauseum, and they are engaging with payers and in unison with health systems to partner with them on how do we help deliver care to an employee situation. I would tell you, we have started within our own employees. So, if you look at the state of Connecticut, we have employees who sit in every single zip code, right? So obviously we know that there are zip codes that are not high socioeconomic levels. So we know that there's certain needs within our own employee. We know that we have chronic disease burden within our own employees. So we actually, back in 2012, we created our own care coordination and health coaching program for our own employees. It is an opt-in program, so no one is forced to enter the program, but there are some incentives for those people who do partake in the care coordination and health coaching. If they have chronic disease, they may get a waived or reduced copay on certain medications. Certain incentives to do biometric screening in terms of reduced premiums. So there's incentives. We are seeing more and more employers incenting their employees to improve their health and how we can be partners in that. And it's funny because, it used to be like payers and the health system sat on opposite sides of the table. We don't see that as much. We really are going more toward partnerships now.
Thank you. And just a few of my own thoughts. You can't underestimate the technology, as Barbara was pointing out. One of my colleagues, a physician who was part of the Center for Innovation at NYP, was just hired by Apple to head up their medical intervention unit. So Apple and Amazon and Google are all getting into this market, and it's going to be coming, they're a lot better at this than we are, right? So they're going to be getting into this market fast and furious, and we're going to have to think about how to keep up with the model. I think the other thing that was a pearl for me this morning with our speaker from the National Quality Forum, which really hit home for me, is the change and the subtle change from a patient-centered care to a people-centered care, which embraces those three dynamics we heard about yesterday of managing not only the physiological and the mental, psychosocial, but then the social. And who would have thought years ago that hospitals would be renting apartments for patients, providing food for patients, providing transportation and taxis and lifts and Ubers for patients. But that's the business that we're getting into as we care about people. And so I think as we think about the classic care coordination model is the RN care manager, the social worker, maybe there's a patient navigator, maybe there's a support person, but what about all those other things? So that we really have to start thinking about the modeling as we move into this next generation. So I would like to thank our amazing panelists for their knowledge and their expertise and sharing their thoughts. Does anyone have any questions that they would like to ask? Any questions? Yes, come forward.
Hello. I was wondering if any of you,
We can hear you. Can they hear you?
you.
You can grab that.
Thanks. Oops, sorry. Hi. I was just curious if you could share if any of you have implemented any standardized approaches for patients with chronic conditions using disease activity assessments that can then populate the patient record in a discrete data field in order to be able to create some clinical action to get to those patients before they reach hospital admission or an ED. I know in Epic and Cerner that these capabilities exist, but I don't know anybody who's really sort of standardized that approach. And I was wondering if you had done any work in that arena.
No, we have not.
No?
Not at this point.
We are just piloting a very standardized approach in urology. And it's basically just articulating everybody's roles and how they interact with the patient and also in the system. And one lesson that we've learned from beginning this work is that historically, and this might be the function or dysfunction of our organization, but I would be curious to hear what's happening within your universe. What we found by doing so is that and we were one of early adopters of Epic like 10 years ago, what we are finding out is that our workflows in the system have been set up in a very siloed way, meaning this is the clinical side and this is the administrative business side. So now we are tripping on, or I shouldn't say we're tripping on those things, we're discovering opportunities for improvement to allow traditional non-clinicians who will have a contact with patient to schedule an appointment or verify insurance to put notes in the system that a clinician could see. So that's where we are right now.
And at Stony Brook Medicine, we have a very large CHF population with a very dynamic CHF physician that leads it. So we've created an esprit de corps of heart failure nurses, and we actually use bots in the medical record where Cerner that pulls out. So somebody, an 89-year-old lady is admitted for a fractured hip, but she's short of breath and on Lasix. So the bot goes, ding, 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 is this the CHF patient? The doctors didn't document it. We don't think about it, because what we care about is the ortho, right? So these nurses mine these bots, and they get these cues, and then they see every single patient in the organization that has symptomatic CHF. And we have a separate part of the medical record that is for the CHF management, and it has dramatically reduced readmissions to the ED. Their readmission rate is very significantly lower, but only in that very small population. So it's a great question. Thank you.
Is that not part of Cerner, or is that
No, it's an IT innovation bot, not part of Cerner. Any other questions? All right, well, thank you so much for a very engaging session.